Top Med Talk.
Hello, I'm your host, Desiree Chappell, and this is Top Med Talk. Coming to you with an update in the COVID pandemic. During the months of March, April, and May, we were really active with daily updates and took a little bit of a break. So we're back to talk with a couple of our guests that we had during that time. So this morning I am joined by first our editor-in-chief, Monty Mythen. Hello, Monty. How are you there in London?
Hi, Desiree. We're doing pretty well. I think normal service is being resumed. It's clouded over. It's been raining.
Back to normal.
And we're easing the lockdown a little bit, which is, and that seems to be accelerating now. So interesting times from that perspective. Let's hope it continues to go well.
It is, absolutely. We'll be talking more definitely within the next, coming months about how everybody's trying to get back to normal for sure. Well, also joining us is a friend of Top Med Talk, frequent visitor, frequent flyer, Mike Grocott. Mike, how are you?
I'm good. I'm with Monty in London, but appropriately socially distanced in a separate room on a separate internet connection.
Yeah, that's right. You are. Well, Mike, the last time we talked to you, you were becoming quite the international star for the news and updating everyone regarding information there in the UK, medical information. So are you still quite busy with that?
So doing a bit less of that. I think more people at the college have now had media training, so the burden on those of us who had at the start of it all has fallen. So I've stepped back from some of that.
Well, good for you. You're doing a great job, though, Mike. I saw a lot of those interviews, so kudos to you. Well,
thank you.
You are very welcome. Well, our guest today with us is someone that we talked to before during kind of the middle of the crisis. A friend of the Top Med Talk family, anesthetist and intensivist from Bath, England. I said it right, I think. Bath, is Tim Cook. Hi, Tim. How are you?
Hi, Desiree. Hi, Monty. Hi, Mike.
Tim,
How are you doing, Tim?
Last time you chatted with us, you said that you were shielding there in Bath, that you had stepped away from direct patient care. Just give us a little bit of an update about your status there.
Yeah, so I've been not physically at work since, I guess, either late February or beginning of March. I've been working. I've had lots of work to do supporting the hospital and trying to do college and other quasi-academic work. And I think the next challenge is working out how to get back to work. So, and I think the challenges for those individuals who are shielded are very similar to the challenges and the uncertainties around restarting scheduled work. So we have the uncertainties about low risk. So we can't create COVID-free pathways, but creating low-risk pathways, particularly for surgery, and then how to manage individuals, what to do in terms of screening patients and in terms of managing PPE and other infection control processes in theatre. And thinking about risk to patients, people will be aware of the COVID surge paper identifying the high risk of mortality in patients who have COVID perioperatively, up to 25%, and also managing the safety of staff, both from infecting each other and from infecting patients or becoming infected from patients. And then if you look at shielded staff, there's that challenge of how to get back to work. We know that the rate of infection in the UK has decreased, but also we've released lockdown. So those pre-existing risks that individuals such as myself are deemed to have had still exist, but it's uncertain whether the environment we would step out to, so we can stop shielding in terms of moving out of our houses, but it's a different thing to stop shielding and going into hospitals and recommencing work in an environment which undoubtedly is of higher risk. And so I think all the factors that impact restarting planned work, be it surgical or other, and rebooting the health service are similar to those challenges for shielded staff. So, for instance, I don't particularly like to personalise these things, but I My big uncertainty is I have a sort of a funny, complicated asthma stroke COPD. I'm not sure if I need to be shielded, but I have been shielded. And I kind of want to get back to work, but I don't know whether I want to get back to work because I'm bored, or whether actually I think that the risk has diminished enough for me to get back to work. The alternative is whether I wait 3 months to see if there is a vaccine, if there's a vaccine.
So, Tim, if in evaluating that risk, and I think this is for both you and Mike, how well informed are we with regards to relative risk of, for example, going to the operating room with somebody who's been through the screening process and is allegedly COVID-19 negative, with your staff members all wrapped up in a particular layer of protection? How's the relative risk of that compared to going to a garden centre, for example? Do we have any sense of that?
So, Jeremy Farrer, who's the head of Wellcome, who's at the forefront of all these things, is pretty well informed about this stuff, and he talks well about it. Two things that I've taken from listening to him are, firstly, that there are effectively three epidemics going on. He describes it in the UK, but in every healthcare service. So there's an epidemic in the community. There's an epidemic in care homes, and there's an epidemic in hospitals. And they each likely have their different epidemiologies. So we've seen the awful events that have happened in UK care homes with a large number of elderly and frail patients dying. And we have a different epidemic in hospitals. So we are now starting to get useful pretty much up-to-date data from surveillance from the Office of National Statistics. So every week now, they publish their COVID surveillance data. And in 3 of the last 4 weeks, they have shown that for the previous month, the incidence of COVID, of antigen-positive individuals within a hospital is between 4 and 6-fold higher than that in the community. So it was about 1 in 200 in the community. At any one time, 1 in 200 would be infected at an individual time. That's now reduced to 1 in 1,000 at the end of May, just before lockdown released, or before it released for normal people. But in hospitals, it's above 1%. So the last figure was 1.8% released last week. And that was 6-fold higher than for individuals not working in the front line in healthcare or care homes. So that means that hospitals are a risky place for patients to come because they might get infected by those looking after them. If they do get infected, the risk of things like surgery is dramatically increased. They're a risky place for staff to work in, both low risk and high risk patients, staff, and they're a risk for individuals who are shielded to come back into. There's some data that I saw very recently. This is what's called the SAFER study, which actually was conducted in your hospital, Monty. So this was a study of antigen and antibody positivity amongst 200 healthcare workers, and essentially taken from asymptomatic healthcare workers in the 2 weeks at the end of March and the beginning of April, which was the peak of activity in London. And amongst those 200 staff, 21% proved to be antigen positive, and 45% were seropositive, so were antibody positive in the subsequent 2 months. So the rates of staff infection within hospitals are really quite high. The analysis that I've done with some colleagues has looked at healthcare worker deaths, which is obviously a small subset of that. But the rates of infection are really quite high. So at that same time, it was estimated that London had an infection rate of about 15%. It's the highest in the country. There was a 3-fold higher likelihood of being infected if you were a healthcare worker.
Mike, from your perspective as one, a clinician, because I know you've been working through all this, two, a leadership position within your facility, and three, kind of in the national world as well, being involved with the college, can you give your perspective on this and what your thoughts are?
I think it's really difficult. The figures Tim quote highlight that, but when you get into issues of exactly who should come back or shouldn't come back to work from shielding and trying to be objective and sensible about relative risk, it gets very complicated because that risk will be different between institutions. It will be different across geographies. We know we've got nearly 50-fold difference in infection rates between central London and, for example, parts of rural Devon. And I mean, using a local example, one of my female colleagues is shielding due to a significant medical condition requiring immunosuppression. She went to see the occupational health team, and they said, "Well, it's up to you whether you go back. You're at augmented risk, but you should understand that your husband, being male, is probably at a higher risk than you are because of your medical condition. The background issues of gender and ethnicity may outweigh the issues related to comorbidities, but how we work out those trade-offs and attach a weight to each of those factors, I think, is really difficult, and it's made even more complicated by it being a dynamic situation. We believe we've got a sub 1 R value infection rate should be going down, but we're releasing lockdown. They might bump up again. So it's not even a target that is stable. It's a moving target, which doesn't provide. That's not a philosophy of doom, but I do think it's dreadfully difficult, and we appropriately adopted a precautionary approach to start with, but we've now got to start restoring surgical services and as much as we can of our old health service alongside managing the ongoing COVID problem. And I don't think we currently have the information or equipment to do that.
Well, Tim, so those figures are pretty staggering when you think about going in your higher risk. Let's talk a little bit about the work that you did in the last couple months, and some of the articles that you had that came out in the HS
Health Service Journal.
Excuse me. Tell us a little bit about that and the articles that you were publishing recently.
Yeah, so it's a sort of strange set of articles, and the story behind it is quite nice. So I became interested, obviously, as an anaesthetist and intensivist, concerns about the safety of colleagues and concerns about the safety of our profession. And in March and April, we started seeing news stories about healthcare workers who had died. And these were added to on a daily basis in almost every UK newspaper. I then started collating that information and trying to triangulate information to create a database of those individuals. I was particularly concerned that anaesthetists, other people working in theatres, our surgical colleagues, and those in intensive care would be high risk. When I got to about 45 cases, I found on Twitter somebody else was doing exactly the same. He was a GP called Simon Linane from further up north than me. And so we combined forces. I've never met him, but now published 4 articles with him. And with him and some other colleagues, either fellows working in my department or other people we bumped into on Twitter, we put together the information. The information was, I've described it variously as scruffy data. Yeah. So it was information in the public domain about healthcare workers and social care workers who had died from COVID, but that data was only available from newspapers or from social media. We tried to make it as robust as possible by getting that information from multiple sources and then collated it. At the time we produced it, it really was the only data in the UK that was available. And there was a few very stark things that came out of it. And the 2 most prominent ones were the very dramatic excess of non-white individuals. So in the UK, we use the term BAME, which stands for either for Black and Minority Ethnic or Black Asian Minority Ethnic. I'm going to use the term non-white because I think it's easier. So The NHS staff is comprised of about 20% non-white individuals. About 63% of the deaths were in non-white individuals. And that has subsequently been picked up on in numerous reports, both in the data from ICNARC, Office of National Statistics data, and from a specific inquiry that the government has undertaken, which I have to say I think has been quite limited. And so over the period of April and May, we unfortunately got up to 200 cases. And in addition to the predominance of deaths amongst non-white staff, the other factor was the absence of any intensive care theatres or theatre staff. So those very people that I was concerned about and that I thought would be overrepresented are absent. And if you look at the international data, that information is still true. And even looking at that study I referred to earlier, that safety study, the one area where there are fewest people who are infected or seroconverted is intensive care compared to the other areas.
Is that intensive care? Is that all specialties? So not just physicians, but nurses and all types of staff?
Yeah, so among 202 cases we had in our last article, there was one intensive care nurse who had died. In the UK, so there were 31 doctors and one dentist, pretty much spread across all specialties, except anaesthesia and intensive care. And anaesthesia and intensive care account for between 12 and 15% of all hospital consultants. So we're very clearly underrepresented in deaths. And of course, looking at deaths, firstly, the source of the data is questionable. Whether we've captured everybody is questionable. And there is a disproportionately low rate of doctors, amongst the doctors, disproportionately low rate of anaesthetists and intensivists.
Tim, I'm tracking all of that, but many of us who are white, who practice in intensive care, have had confirmed COVID-19. You referred to that earlier. It's how hard it's hit us that's the point, I think you're getting at.
These are just deaths. And what we really need to know is the rate of infection and hospitalisation and admission to intensive care. And that data isn't available. So we took what data was available. One of the questions I asked the college was, do we know the proportion of anaesthetists and intensivists who are non-white? We don't currently know that. That wasn't collected in the surveys. I hope it will be in future surveys. So we don't know our risk profile. On the one hand, it's good news for anaesthetists and intensivists that although we are very clearly working in a high-risk environment, the precautions that are taken, which include but are not limited to PPE, seem to be protective. And it's equally bad news, I think, for those individuals working in other environments, particularly early on in the epidemic in nursing homes, who weren't protected. And whether this is due to behaviours or to PPE, which everybody focuses on, is uncertain to me. So, for instance, we are all used to working in an environment where we don't touch certain parts of the environment, and this is all to protect patients, where we go into rooms and put aprons on and gowns for patients at risk of infection. And so we're used to those processes. The process has been changed to protect ourselves, and we're used to hand washing and being scrupulously clean. So whether it's the PPE per se, or whether it's our familiarity with those processes, which perhaps are less familiar on the wards and in nursing homes, I suspect it's an interaction of the two.
In the UK, in the OR, so anesthesia staff, do they wear masks the entire time during surgery?
No, is the simple answer.
But do you when you intubate?
No. So prior to COVID-19, I'd say that the only time, everything varies by region, but I would say the only time that people have paid any interest in the risk of infection when intubating has probably been when intubating patients on IT with meningitis or with some other
TB or something like that.
Clearly known infectious disease. But it's just not been practiced. I think everything will be changed utterly afterwards.
Yeah. I mean, obviously that's a standard in the US. I mean, you wear a mask anytime that you're doing a procedure, and if you're in the, you're intubating or you're in the OR, to see, rates of infection and things like that. Because I mean, we clearly are used to wearing, full mask and everything. So just an aside. Anyway, sorry, Monty, go ahead.
Well, I was saying we used to, when I was a youngster in medicine, it was normal to wear a mask the whole time in the operating room at the hospital where I trained. But as we travelled that journey over time, it became the norm not to wear a mask unless you were in the wound area, if you sort of mean, and
over
or
the Serofield.
There was a prosthesis of a certain form going in. So it would be unusual to see people out with the people performing the surgery per se to be wearing masks in the UK.
I think even the surgeons don't always wear masks. So colorectal surgery, surgeons will often not wear masks.
No kidding. Huh. I did not realize that, actually.
Well, it's an evidence-free bias, if you see what I mean.
Mm-hmm.
So it's one of the totems of practice.
It is.
But it's uncontaminated by data.
And I think, so we mentioned this on the previous podcast, but I think the government early on, the UK government early on had one of the lines that they come out with, and that was that there was limited evidence of a minimal effect. And I think that probably remains the effect for general mask wearing. We have moved to a circumstance where I think globally people are going to be wearing masks in areas of relatively high risk. We have to remember that the simple surgical masks probably have a significant effect in reducing droplet dispersal to others, and therefore are worn to protect others, not the individual wearing them. And then the tight-fitting, the FFP3, FFP2, and N95 masks are worn to protect the individual wearing them. So they filter incoming, and then 95 or 100 is the percentage roughly that they filter. And N95 FFP3s, when they've got a valve on the front, when they've got a plastic valve on the front, then they are only protecting the individual, because that valve is an expiratory valve through which you breathe through. So anybody who's seen in a hospital wearing one of those masks which has a valve on should have a face mask on top of that, so that they're then protecting both themselves and those around them in case they happen to be one of those asymptomatic infectious patients. I think there's a lot of simple misunderstanding around that.
Yeah.
Now, Tim, it's hard to keep track of the changes in different countries, but it seems as though we're about to enter a period of reasonably universal close quarter face covering and the widespread adoption of mask wearing in hospitals, which some might think is a bit slow to arrive and some might think is probably after the horse has bolted.
Yeah, I going back to that element, I think there is, as you said, it's evidence-free. I think there's limited evidence of genuine benefit. But we are in a circumstance where every little bit helps, and I have changed my view on how things should be. In public, I think we increasingly know that this is a disease spread by proximity and duration of proximity. So if I was in a car driving to London with somebody I didn't know, somebody I wasn't living with, then I would wear a mask. If I was on the tube in London, I'd wear a mask. If I was walking down the street in London, I wouldn't wear a mask. And then in a hospital, I think we have that epidemic which remains more active in the hospitals by several fold than it does and that's just amongst the staff, irrespective of the patients. Yeah. There is the risk of staff infecting each other, etc., etc. We've had a hospital in the southwest of the UK closed because of high rates of infection amongst both staff and patients, and I think that can happen. So we're not going to get a surge for a while, but we're going to get a rebound of the first epidemic, and those are likely to be centred on hospitals. Change my view. I agree with the wearing of masks within hospitals.
Yeah, and I've been a fan of it from the get-go. It just seemed rational to me on the basis of the infecting each other in close quarters in hospital, because it's very, very difficult to stay apart in hospital.
What has come out in the UK now from your national organizations? Has there been official data that's come out?
It's rather limited. The BAME issue has been, or the non-white issue has been hugely important. And of course, we're talking a few days or the day after George Floyd's burial. I think the whole non-white issue around COVID and the factors that increase the risk of non-white individuals' risk of death during this pandemic have or contributed to a completely different social revolution, which I think is happening around us. very interesting and important discussions around systematic and individual racism. And the exposure of, so there is no doubt that individuals who are not white, whether staff or patients, are at significantly increased risk of mortality from COVID. The reasons for that are multifactorial and complicated and not completely disentangled yet. Originally, there was quite a lot of emphasis on, as it were, genetics and ethnicity and the vitamin D story. And I think that's probably been pushed slightly further backwards. And the ideas of sort of social geography, the non-white individuals predominantly living in urban settings, probably with overcrowding, in multi-generational houses, doing jobs which are more likely to be key workers and having to leave lockdown. Those factors are more important. And I think even within the healthcare environment, non-white staff are more likely to take those jobs which are, or to be appointed to those jobs which are lower in the hierarchy, and expose them to perhaps to those areas where PPE is not available. They're more exposed to direct patient care. So I think all those factors, and then you add on to that the element that certain, so some Asian and Black individuals are more likely to have diabetes, hypertension, cardiovascular disease, in some cases obesity. All those factors which are known risk factors for increased severity of COVID, not necessarily for more likely to get it, but increased severity of COVID. So I think all those factors interact. I probably missed out a couple. But that, within that, there's some genetics, there's some social injustice, and it's a complex area. Mm-hmm. I think when you then try to, going back to the healthcare setting, when you try to disentangle risk factors for, say, for shielding or for coming back to work, or for individuals who are at work, but how you factor that in, then ethnicity is a really important factor to have in those scoring systems, but it's only one. Mm-hmm. So age trumps everything. Yeah. And I've been there were quite a few risk scores that say, your risk really increases above 70. And yeah, it does really increase above 70, but actually it increases above 40. It increases from 40 to 41 to 42 to 43, etc., etc. So when we wrote airway guidelines pretty much in the first week of things kicking off in the UK, we suggested that staff aged over 60 probably shouldn't be intubating. And I think that 70 bar is too high. Yeah. So there are a lot of risk factors. BAME, being non-white is an important risk factor. But I think it interacts. It's probably so. There's a really good study done by Ben Goldacre and many other researchers, which uses big data from the UK, and it looked at our electronic patient records for 17 million patients, and then collated or joined together the outcomes from those patients who then come to hospital. So it only looked at hospital deaths, but it looked at risk factors. So we've had excellent studies from ISARIC, which looked at patients who admitted to hospital and how they fared when they had COVID. We've had IGNOT data, which looked at patients admitted to ITU and looked at how they fared with COVID. But what this did was it looked at the whole population. So it combined both those risk factors for getting the disease and how well or poorly you fare if you have the disease. And the risk factors that were most prominent there were age and being male. Mm. And those were absolutely the most important. Mm. So if you were over 60 compared to under 50, you had sixfold increased risk of mortality. And if you're 50 to 60, you had threefold increased. The other factors, which were all around 2 in terms of increased risk, were being male, having diabetes, particularly if it was poorly controlled, and being significantly overweight. Being non-white only increased risk by about 1.7. So it's only one of those factors. Yeah. I think it's a really useful study, and its strength compared to a lot of other studies was that it used multivariate analysis to extract the risk factors so that those were independent risk factors, and it looks at the whole picture. But I think there is, although that's hugely valuable, I think it's also important to separate the two risks. The risk, is there increased risk of getting the disease, and is there an increased risk of consequences if you get it? And I think that hasn't been sufficiently disentangled yet. And I think that will be an important next step. Mm-hmm. And for a lot of the people who are shielded and who should be shielded, the risks are about the severity of illness if you get it. And I think in that group, hypertension, cardiovascular disease, and diabetes are probably equally or more important than some of those other factors. That seems to be from looking at a lot of the literature from China, Italy, the UK, America. Those are very consistent findings, and those seem to map to poor outcomes. And I think perhaps more so than, say, respiratory disease or immunosuppression or pregnancy, which don't seem to map in the same way.
Tim, just towards the end here for a moment, Desiree, one question that I want to get answered from you, so I've toyed with this myself. If you had an antibody test and it came back positive, would your attitude to returning to work change?
I've got on book for Monday. I finally got it on the phone line. Yeah, so I've not been at work for 3 months, but my son came back for university, having been on a celebratory party before he came back, and it's just possible that we were all unwell for a couple of days. A close colleague who has been at work intermittently unexpectedly tested antibody positive this week. Oh. So there was a lot of concern early on that the antibody response was transient, that there was uncertainty as to whether being seropositive would be protective. There were a couple of reports, some rumours and some actual reports of reinfection of individuals in Japan. And so there was the concerns that A, it wouldn't provide immunity and therefore you might get it again, although the expectation was it would be less severe, but also that you might get it again and then be a spreader. So, but I think those concerns have started to somewhat reduce. I think the sort of trending opinion in the literature seems to be that those people who get an antibody response, that most people get an antibody response, that it seems to be sustained. Whether it's protective is uncertain, but I think those early concerns have somewhat reduced. The Department of Health or NHS England specifically states that if you are antibody positive, you should take the same precautions as if you're not, in terms of how you protect yourself and how you protect others from you. And I think that precautionary approach is quite right. But would it reassure me? Would it make me personally more likely to go back to work? Yes, it would.
Thank you.
That's right. Yeah, great.
I think there are now risk tools available. And we are in the process of trying to produce a risk tool for shielded doctors in the UK as part of the College and Association response. That hopefully will happen in the next couple of weeks. I think it will largely rely on that Ben Goldacre open safety study that I described.
Yeah.
But I think one of the key messages, I mentioned Jeremy Farrar, and the second thing that I think is really important that he said is that this is now an endemic disease. So we've moved from what was going to be an epidemic, a disease that rises in prevalence and then decreases to the point of disappearing. That's not going to happen, at least for the next 2 years or so. And so it's a disease that we have to live with and alongside. And there's no certainty that we'll have a vaccine. We all desperately hope we'll have a vaccine. But if we don't, or that takes longer than September or October, as has been wished for from the Oxford vaccine, then we will be living alongside it. And we need to move from the responses in March and April, which were reactive and emergent and of necessity short term, and accept that this is a problem at least for the next 2 or 3 years, and start to plan strategies to work out how we in hospitals as well as society move forward for those 2 or 3 years, because we can't just do things on a month-by-month basis. It has to be a longer-term strategy.
So what are some of the places that are offering some high-quality information for providers in the healthcare field?
I mentioned before that hub that we have for anaesthesia and intensive care.
Do you have to be a member?
No. It's all free access. Google COVID ICM anaesthesia, perhaps with hub. Then you'll get to the. It's a joint website of those 4 organisations. That's Intensive Care Society, Faculty of Intensive Care, Association of Anaesthetists, and Royal College of Anaesthetists. And those organisations have been working actively together to ensure that they are not in silos and that they speak with a common voice. And that has worked fantastically effectively for the last 3 months. And I really hope that the lessons learned from that are carried forward, that we do not become tribal, we do not point score, but we try and work together. And I would expand on that to say that we need to work together with surgeons and theatre staff, and intensive care nurses and physicians, and so that we can plan this next phase, this working with COVID, and hopefully at some point working beyond COVID together. Because one of the problems has been multiple guidances which are conflicting from different organisations, and that has sometimes had very significant consequences when poorly thought out guidance has been thought out. And when organisations work together, we've learned that they can still do this quickly, but probably the quality of product is improved by having multiple organisations not looking at in a one-eyed cyclops way at their own specialty alone.
Yeah, I mean, it's just not practical. We all work together every day. So, well, Tim, I want to thank you so much for coming back on Top Med Talk and discussing this very important topic. I think we are going to be, as you said, dealing with this for a very long time. So important to get the message out. So appreciate all the work that you're doing in this space. Keep on tweeting. It's good stuff.
Nice to see you both. Take care.
Thank you so much.
We'll see you at EBPOM London 2020.
That's right. Going
live on the 30th of June for 3 days. Lots of conversation. Now we're actually going to be going around the globe, so we'll be running 24/7 for people who want to pick it up around the world. So see you all there.
Absolutely.
Yeah.
Top Med Talk.
All right, EBPOM 2020. Well, thank you for listening to Top Med Talk. Be sure to check us out on social media, Twitter, Facebook, LinkedIn, we're there. And coming to you over this next month with all things EBPOM. That's our goal, to get to June 30th with all that great stuff. So thank you for listening. Be safe, stay well.